This week, I'm talking about some of the new plans for asthma care by general practitioners in the United Kingdom, with a particular focus on asthma reviews. Now, this episode will be of interest for healthcare professionals in other countries as well, and also for people with asthma, of course, parents of children with asthma, and also for doctors and nurses caring for patients. Now, since 2020 in the UK, general practitioner pay has been dominated by the so-called Quality Outcomes Framework. It's called QOF for short. In essence, the authorities require general practitioners to record certain indicators and tasks on their computers in order to be paid. Now, for asthma, there are 4 of these items, and these are to maintain an asthma register, to record how the diagnosis of asthma was made. The third item is the percentage of those people with asthma who've had an asthma review in the last 12 months. And finally, the fourth QOF requirement for payment requires a record of either personal smoking status or exposure to secondhand smoke in the previous 12 months. Now, while these are all important and useful, I really question the sense of simply paying GPs to do one assessment a year, which may not yield any useful information. So in this episode, I'm going to suggest some ways that both people with asthma, parents of children with asthma, and also general practice or primary care provider team staff all work together to cooperatively reduce asthma attacks, reduce suffering by patients and families, to reduce the workload that's generated by unscheduled care, and to increase satisfaction by all. Now, before I continue, please do click the follow button for my Asthma Spotlight podcast so that you get an alert whenever a new episode is published. Okay, so what's the problem? This is that asthma is a chronic ongoing disease which flares up from time to time. And these flare-ups could result in acute, severe, life-threatening attacks, most of which can be prevented. So the UK requirements for the annual review are excellent, i.e. that the diagnosis is checked, that an assessment of how well controlled a person's asthma is, that the provision of or update of a personalised self-management plan is provided, a check of adherence to medication, and optimization of drug treatment based on the level of control, which includes inclusion of attacks in the previous year. And here comes the but. As I said, asthma flares up from time to time, and because treatment optimization will be considered if someone's asthma is poorly controlled, and not if it seems to be well controlled, the timing of the review is vital. So if a review is done on a day when your asthma is well controlled, then it's unlikely that any changes in treatment will be made, even if you've had a number of asthma attacks in the previous year. So firstly, for people or parents of children with asthma, if you or your child have asthma, it's really important to ask for an urgent review by your doctor or trained asthma nurse if your asthma is poorly controlled, at the time that it is poorly controlled, rather than waiting for an invitation for an annual review, which may not be done at the right time for you. And of course, for doctors and trained asthma nurses, a timely review when someone's asthma is poorly controlled will be far more beneficial use of your professional time, because when asthma is uncontrolled, it's essential that treatment is optimized, and that's where you utilize your skills, and at that time you can help to prevent a future attack. Okay, so the next question is, when is the right time for an asthma review? Firstly, the most important time for a review, in my view, is soon after being treated for an asthma attack. Because an asthma attack signifies that something serious is going wrong with your treatment. And that includes soon after being admitted to a hospital for an acute asthma attack, or soon after attending the emergency service provided by general practices, or attending the accident and emergency departments, and also soon after being treated with high doses of reliever medication, either using a short-acting reliever, which is usually the blue inhaler, and the drug is called salbutamol or albuterol, or a nebulizer. And of course, soon after being prescribed or using corticosteroid tablets for an asthma attack, would be a good time to ask for an urgent asthma review. Now, next time a review is needed urgently is as soon as possible after two thresholds are met. And these two thresholds relate to prescriptions for short-acting bronchodilator reliever inhalers, that's salbutamol, albuterol, or terbutaline, the ones that are usually blue, and prescriptions for inhaled corticosteroid preventer drugs. So let's look at the first one of these two thresholds. So when should we worry regarding reliever inhaler prescriptions? Now, the whole point about reliever inhaler drugs is that they are really meant for emergency treatment of symptoms when they flare up, and for treating asthma attacks to quickly relieve the bronchospasm or tightening of the air passages. Now, these inhalers, which I've said are usually blue, only work on the tightening or spasm of the air passages, and they do not work on the underlying cause of the asthma, and that's the inflammation. And the other point about these relievers is that regular use of these drugs, these are the blue inhalers, can cause attacks or even deaths. So we know from research like the National Review of Asthma Deaths in the United Kingdom and the more recent studies in the research literature that more than 2 prescriptions of blue inhalers in 12 months are associated with increased attacks and the need for hospital admissions, and also are associated with deaths due to asthma. So the time that an urgent asthma review is needed is as soon as someone requests their third blue inhaler. That's the time for an urgent asthma review. So the key message for people with asthma is to request a review as soon as you've requested your third blue reliever in a year, and for doctors or anyone responsible for issuing or monitoring prescribing, and that includes practice managers, practice nurses, and practice pharmacists, should urgently expedite a detailed asthma review by someone trained to do so, who can identify and fix any modifiable risk factors. And these modifiable risk factors would include things like poor inhaler technique or failure to collect inhaled corticosteroid preventer inhalers. And the other key message for prescribers is to ensure that patients can get an emergency inhaler if they need one, but to note that that's a signal that the person needs an urgent review. So receptionists, nurses, pharmacists need to be aware of this, and if someone asks for one of these drugs, they should be offered an urgent appointment. And also, these drugs should not be included as regular items that can be requested without a consultation. So we now come to the second threshold for asking for or for initiating an urgent asthma review. And this relates to the prescriptions of inhaled corticosteroid preventers. And in the case of these inhaled corticosteroid inhalers, the signal for a review is when not enough of these inhalers are being prescribed or collected. Now, current evidence in asthma guidance and guidelines is that everyone with asthma should be prescribed an inhaled corticosteroid either regularly or as needed. So why is this advice being promoted? The reason is based on published evidence in the literature, and it's because asthma is an ongoing chronic disease. It's there all the time, and it's prone to flare up from time to time in the form of an attack, which may be life-threatening. So the idea is that the disease can be damped down and controlled all the time with these inhaled corticosteroids, and not just when there's an attack. So the key message for people with asthma or parents of children with asthma is to take note of how frequently the drug has been prescribed, so you know how frequently you need to request and collect the prescriptions. The frequency will also depend on how many puffs you need to take each day and how many puffs are available in each inhaler. So how often you need to collect a new prescription should be clear. If you're not sure, then ask your prescriber. The type of prescription and the severity of your child's asthma will determine how often you need a refill prescription. This prescription may be daily, twice daily, and there's also a way that these inhaled corticosteroids are prescribed where they are combined with a quick-acting, long-acting reliever called formoterol. And these are used either as needed in people with so-called mild asthma or as maintenance and reliever treatment regimens called MART treatment, where you take 1 or 2 puffs a day of this inhaler, the combination inhaler, and you use the same one for relief of symptoms. So in addition to regular use of these inhalers, the combination inhalers, you also use the same inhaler for symptoms instead of a blue reliever inhaler. Now, of course, it's important for you as a patient to recognize when you need to collect a new prescription for your preventer. But it's also important for prescribers and for general practices or primary care providers to need to implement systems that detect when someone or when a parent are not collecting enough inhaled corticosteroid inhalers. And as soon as a collection is missed, the patient should be contacted for an urgent review to identify and fix any modifiable risk factors. And these factors might include safeguarding issues where a child's parents are not collecting sufficient preventer medication for their children's asthma. Now, the last suggestion for needing an urgent review is when someone with diagnosed asthma or someone who was previously prescribed an inhaler and has not been diagnosed with asthma consults with respiratory symptoms. So this is an opportunity. It's a signal when somebody's asthma is poorly controlled that their asthma is out of control, and instead of a prescription for a cough mixture or an antibiotic, they need an urgent assessment for their asthma. And this needs to be done by a doctor or a nurse appropriately trained in asthma care. So I've suggested some of the ways that both people with asthma and parents with children with asthma, and also general practices or primary care provider team staff all work together cooperatively to reduce asthma attacks, to reduce suffering by patients and families, to reduce the workload that's generated by unscheduled care, and to increase satisfaction by all. So the key messages are for people with asthma to ensure that a detailed asthma review is done at the time that is needed, rather than just at an arbitrary date chosen at the convenience of the doctor. And this includes whenever you have an attack. It includes when you're collecting excess short-acting blue reliever inhalers. It includes when you're not collecting or being prescribed sufficient controller or preventer drugs, mainly the inhaled corticosteroids. And the other time that you need an asthma review is if you're consulting for symptoms like respiratory symptoms of coughing, wheezing, or shortness of breath, and your asthma is uncontrolled. Now, these reviews must be done by either doctors or nurses who have up-to-date working knowledge of the asthma evidence. And finally, please do have a look at my website, www.bigcatdoc.com. You'll find lots of information on there. In particular, have a look at my 7-step plan to eradicate asthma attacks, because these are a clear signal that something serious has gone wrong. I have put a link to this 7-step plan in the description below. One last final note is that it would be helpful if primary care practices and primary care providers allocated at least one slot every day in their appointment system for doing an asthma review. If the slot's not used, it can always be utilized for another patient. But if there's availability for an asthma review every day, then it's likely that more timely reviews can be done for those people when they need them.